Now what I'd like to do is introduce Casey Shuley. There he is. I'm like, he's gone. Casey's gonna talk to us and facilitate a little group to talk about the Region 9 evacuation situational awareness exercises and lessons learned. So if the panel members would like to come up and go ahead and have a seat, or as Casey introduces you, we'll get through this.
So we have a little bit of time to go over this exercise real quick, and we've kind of been talking about this the last few coalition meetings, so let me do a quick recap. The focus of this exercise is centered around hospital evacuation, but we also built in a component of it to touch other healthcare facilities during the exercise. The reason why we did that was to help other healthcare facilities meet their exercise requirements, but also help the coalition practice our situational awareness process. So the situational awareness process was one of our objectives, but there was also DMCC activation, disaster coordination center activation. Disaster Medical Coordination Center activation, and patient transportation coordination. There were a lot of different healthcare facilities involved in this exercise, but for today we have a few of them represented up here. I'm going to speak on behalf of Newport today, just in general. Heidi Williams she's the Eastern Washington Healthcare Training and Exercise Coordinator for Region 9 Healthcare Coalition. And she's going to speak on behalf of Perry County Memorial Hospital. And then we also have Barb Richards from Providence Holy Family, and Chet Reshetko from Horizon Hospice Palliative Care. All right. Okay, so in general, I'm just going to give a brief overview of Newport's hospital play. They were pretty critical for this exercise since they were actually an evacuating facility. They did one of the things in this exercise that we wanted to emphasize was evacuate how you would in a real scenario. We tried to limit simulations on this as much as possible. So part of that included activating their internal emergency operations plan, which they did. So part of that plan included, first option, discharge patients if you can. So they worked through the scenario a little bit and discharged almost half of their patients. And then they reached out to local facilities, including local skilled nursing facilities, and tried to place patients on their own. Then after that, they contacted the DMCC. So they reached out and said, we're evacuating, we need help placing patients. And then the DMCC was actually able to help place patients in a neighboring county. Some challenges they encountered were minor ones. You always say the devil's in the details, and really one of the things that came up that caused a hiccup initially was calling the DMCC and saying we're evacuating, we need to place patients. Doesn't necessarily activate DMCC. So maybe just saying we need to activate the DMCC could have solved that problem quickly, and they could have moved on. Another challenge they experienced was notification of their staff or off-duty staff, which I've seen a number of times. There's a call-down list of staff, and every time I do an exercise on that with the hospital, there's always updates that need to be done. So those were two minor challenges they experienced, but some strengths were in their patient placement. They did a really good job, like I said, placing patients locally on their own, and then escalating it up to activating the DMCC. They also did a good job at reaching out and working with county emergency management. That's something that we try to reiterate with all the exercises that we do, is let your county emergency manager know if there's an event going on. So they were actually able to contact their emergency manager through their local dispatch center, and they were able to find a unique transportation resource that wouldn't have initially been considered, which was actually a Kalispell tribe resource. So it actually worked out pretty well, and they saw a lot of value in working with their emergency manager. Okay. Real quickly, I just wanted to touch on our situational awareness process. And so during the process, we notified 50 agencies, sent out our survey to collect data from those agencies. 34 of those agencies responded, and we sent out the situation report from that data to roughly 75 different agencies. And then we collected feedback from about 10 facilities after the exercise on the process and everything. So that's something we're going to be doing multiple times throughout the year. We're constantly updating that to make it better and more valuable for everybody in the region. So be looking out for more exercises on that. Okay, next is Barb.
So I was the lucky short straw, I guess, for the DMCC portion of this. So as you said, a little snafu in getting us kicked off, but we were able to get it started. I guess on my end, geographically, even though I know where the hospitals are, it would be nice to have a sheet of paper that just kind of pinpointed a line map that says this is Newport so many miles away, this is Tooele so many miles away, it's Colville so many miles away, whatnot, that with that. And then also I had personally just multiple pieces of paper that had different notes and tried to keep the facilities separated so I knew which patients were coming from which hospitals, and then activating the DMCC, the WATRAC, so that people updated their boards. And then once I knew from Newport how many additional patients needed to be placed and the acuity of those patients, knowing that Holy Family didn't have to take all of them, that I still had resources out there to keep them closer to home and just sent them off there. So I don't know. Any questions on that? I mean, for a first time, I thought, okay, I got this sort of. Oh, okay. So the snafu from the trying to activate the DMCC, that was the question, came one, we found out very quickly we needed appropriate phone numbers. They called our house supervisor, who happens to be just one of our managers of one of our units, who has no idea what's going on. And they called her twice and she played along and she was really nice and did that. But instead of that, they should have called directly to the ER. So there were a list of phone numbers that will be updated to make sure that when we're calling out, we're talking to the directly to the people involved that need to be involved right at that moment, not anybody higher up than me, because they're not going to get down to me. I will contact beyond where I need to go, but we needed those numbers straight to the emergency departments, to the person in charge that day, so that we knew what was going on. Got another question. Yeah. Yeah. We want to activate DMCC, not we want to activate our hospital. What can you do to help us? That's kind of the question there. So the language was a big deal to make sure that we're all on the same page with language. So having that language laid out in our books, because I'm not all, you know, we all know that in emergency department, we have various charge nurses or managers that are there, so that when we open up the book and it says activate DMCC, we all know that that means do this. So we talked about language, we talked about phone numbers, resources out there that are available to us. And then a big one for us, for me, when we start this, especially if they're all coming from the north side, is I have the grace of time in that you're not going to be at my door in 5 minutes. You're going to be at my door in an hour, or you're going to be at my door in an hour and a half, or you're going to be at my door in 2 hours. So it gives me the opportunity to get you those phone numbers in those places, those resources that need to go out. And as I called facilities and found out what they had a bit for bed availability or potential bed availability, they were all really great. There was one that called that was a little flustered, but she was so cute, and I just played along with her, but it all worked out just fine. But that was the whole idea, is that, you know what, we're going to play this game. Nobody's going to know. We're going to do it real time. Let's see what kind of response we get. So yes. So the question was, as far as transporting patients, acuity of those patients, and transport trauma, transfer trauma, how do I decide as the DMCC organizer of where they go as to what facility they're going to go to? Okay, so what we did with that is once I got more information regarding the patients that needed to be in a facility, provide medical care for them, once I got down to the nitty-gritty of acuity on those patients, it was easier for me to decide what facility they needed to go to. If I have a stable patient who's in a hospital, who's got pneumonia and only needs oxygen, he doesn't need to go, 50 miles from home. There's a closer facility that can still monitor him, give him his antibiotics and keep him on oxygen, right? But those who needed a little bit more care as far as more intense or interventions and that type of thing, those would come into actually a facility that would be able to take them and continue with their care to make sure they're getting the appropriate care. Any other questions? Thank you.
All right, next up is Heidi Wilson.
Hi, I was able to be at the Ferry County Memorial Hospital when they were doing their exercise. It's a 25-bed acute care facility that has 12 of their acute care beds as swing beds. And the day that we did the exercise, all 12 beds were actually being used for long-term care, and they had no acute care patients. So we pretended like they had 2 acute care patients, and we tried to create scenarios that had patients that would be likely to have stayed in that hospital for a certain duration and then be needing to be transferred to another hospital, but not acute enough that they'd be transferred down to Spokane. So we tried to keep them that they would be transferred sort of within the like Stevens County area. So given that, they were actually able to find their beds very quickly, within about 45 minutes. We actually had to hold them off on directly calling hospitals themselves for the acute care patients, asking them to go through the DMCC to really drive that exercise play. So sort of working through some of those challenges that we ran through. So that did cause a delay, but a necessary delay to sort of work out those kinks and practice that. They did find their own long-term care facility beds, calling around, and they were able to do that within 45 minutes. They actually found, I want to say 5 long-term care facilities and a redundant number of beds. And with transportation, that they had some strengths there and a bit of a challenge. For their acute patients, they called dispatch and immediately got their acute care patients transferred. That was not a problem. With the long-term care, they had their own ALF bus that had seats for 10 and 1 wheelchair, and they needed to get a few more, so they contacted the school. Then the school said, we'll get back to you. But because of the exercise, they wanted to kind of hurry that up a little bit. And so they ended up using a lot of their own personal relationships to get their transportation sorted out. They did it very quickly. The challenge was that they felt that because they had relied on personal relationships, if that person didn't happen to be there at that time, that would have caused problems for them in the future. So they thought that a lesson learned would be to have more formalized processes and working through their emergency manager to kind of support that and facilitate that process. In terms of other areas of improvement, they did have a great internal collaboration. They identified, though, that their internal communication system was a bit of a source of a challenge. The team came together quickly to start working on the evacuation, but some of the key members of the team did not receive the initial notification, so they were a bit late. And it was because the comm system that they used didn't actually go into all of the rooms, and one of the nurse managers was in one of the facility rooms. And then another strength that they didn't immediately identify, but I just thought was worth noting, was that they really used the exercise as a way to not just test the objectives that the planning committee had set out, which was on patient placement and transportation, but also looking at what were some of the internal facility challenges that they would really need to work through. Specifically, I'm talking about the fact that they were they still needed to be remain an effective critical access hospital due to the remote area that they were working in, and a lot of their community was off the grid, and so if they had a communication out to the wider community about the fact that the hospital was closed, people wouldn't have necessarily gotten that message. So how do they still remain semi-functional even though they're going through an evacuation? So that was an important conversation that they were having. And I just wanted to note, the bottom picture up here is actually their incident command center. It's a trolley, and I thought this was a really neat approach. It allows their incident command center to be travel size. And at the day of the exercise, they had no meeting space. So we ended up meeting in the executive director's office. And so they were able to wheel in their command center with all of their relevant materials and planning tools. So I'm getting the time button, so I need to move on.
All right. Good afternoon. I'm Chet Reshetko. I'm the Director of Palliative Care at Horizon and Palliative Care. Our facility has about 90 plus personnel, 30 of which have been hired since June. So in this very, very rapid growth of the company, we have about 300 patients, all of which are either at home or in a retirement community. So that's their home. So we have no patients in our facility per se, but we're all on this outreach. We, amongst those two hires have been two Air Force retired colonels who come with tons and tons of disaster, hurricane, tsunami, real world, real flu experiences, both local community, statewide, national, and international. So we've been able to bring a lot of real world things to it, including personal response on the rescue side and then the rebuild after Katrina. So you can imagine our little company has suddenly, whoop, oh, like, wow, these things can really happen, and we've been able to talk them through it. In addition, all of our staff, about 70% of our staff at any one time are outside the building. So the communication has to be there. We adopted our scenario because we don't have inpatient care to that our facility was non-functional. So the HVAC went down to such a degree that we could not utilize the building. We did say we could access it, but we could not utilize it. So that was our scenario, that we had to figure out a way to communicate with all of our staff, keep everything going, and communicate with our patients and with their families, which is a huge part of what we do. So at any one time, 70% of the people gone. That included, at the moment this kicked off, that 3 out of the 4 of the top people in the company were gone. So that left it up to those who remained to do it. But fortunately, to Air Force retired folks, and we were very comfortable working through it. In a minute, we were able to get the emergency plans that are stored in 2 different places in the building. They had them, and so we were involved right away from a critical thinking standpoint, and we were ready to go for that. What wasn't good is that we weren't 100% familiar with the plan. It's in the box, and somebody every once in a while looks at it, but the people in the room weren't completely familiar with it. So we had these feelings of what we should do, but did not always align with the plan, nor parts of the plan weren't updated in the facility, especially the communication roster, which once a month gets pulled over to the secretary's desk to update the new hires, and guess what day she was working on it. So it happened to be right when this happened. So we, from an organizational our actions, we have since put together a robust process by which we update the communication products. They're updated and they're posted in real time, not waiting for once a month as new people come on and go off. That's done. We've scheduled monthly and quarterly emergency preparedness plans and documentation reviews by the people who would be going into them. So all of us, every year, twice a year, we have to be the ones who go in and look at them on a monthly basis to make sure they're all up to snuff, but that will require us to be familiar with them. And then we did a communication-wide, or excuse me, company-wide communication to everyone. Here's the documents. Now it's also part of the orientation where the new employees actually, within the first 2 weeks, have to actually sit down with our emergency coordinator and walk through that, not just give it to them in a pile of other paperwork, but actually sit down and walk through them. The next thing, also we had the alternate facility, which is in the community. We had not ever done anything with it, and we know it's available, we know it's there, but not even everyone knows the address in a sense, or have it plugged in. And so we'll make sure that's all done, and we'll actually go to that facility at some point and do a walkthrough to make sure it's there, and to store some products just in case we can't access the building, so some of them are there. And then the policies adjusted. Oh, and oh, by the way, we're starting a brand new EHR on December 1st. So not only wish us luck, but that will also change our disaster plan because it has some capabilities that we currently can't do electronically. So that's what we'll be doing. And that is it. If you have any questions, I will be more than glad to entertain them. All right. Thank you very much.
All right, so real quick, I just wanted to bang the drum a little bit more on the upcoming exercises. So we do plan to repeat this 2 more times. The next one is going to be the last half of February. At least that's the proposed 2-week window. And again, we try to do these exercises at a sub-regional level and incorporate other regional partners through our situational awareness process. And that's a theme that we're going to keep continuing to do with these. Here's our schedule. Like I said, the next one, last half of February. The third one will be done sometime in the May timeframe, but those are all tentative right now. Of course, sub-regional exercise players include hospitals, county emergency management, the coalition, public health, and EMS. And then for regional play, we look at the coalition again, and then individual healthcare agencies would be like long-term care, skilled nursing, and home health agencies, just to name a few. So a quick question, are you participating in the next one? Again, it's the last 2 weeks of February. The sub-regional exercise planning team has been picked by me, and I've reached out, and I'll be coordinating with them. But if you want to participate at a regional level, the first step is to sign up for our situational awareness process, and we'll bring you into the loop of how to play in the exercise that way. Now, I don't have time for questions, but if you guys have questions on the exercise and what's going on, you can always email the coalition at hcc@srhd.org or give us a call.